Tim, thank you so much, Deputy Chief Justice Moseneke. We are doing a joint presentation or a presentation. We submitted our presentation on the 18th of June last week. We would like to thank you so much for giving us this opportunity for doing this oral presentation. So this presentation is being done with two joint civil societies who are the People's Health Movement South Africa, which is PHMSA in short, and Health Justice HJI in short. So basically, the Health Justice Initiative is a dedicated public health and law initiative that is addressing the intersection between racial and gender equity with the racial focus on access to living diagnostic treatment and vaccines for COVID-19, TB, and HIV. Whilst the People's Health Movement is a civil society organization that is committed to the realization of the right to health for all in South Africa, its mission is to improve the capacity of individuals and communities to realize their right to health and health care. And it also advocates for the primary health care as defined in the Alma Ata Declaration of 1978. In our presentation, Chief Justice, as I continue, in this joint PHM and IJI joint submission should not be in any way be constructed as support of, against, or hosting of local government elections in 2013. We strongly believe that whether we proceed or not, this must be decided on the expertise input and devices and subject to review our courts, because there is highly contagious contagious of political nature and the issue at hand in the pandemic. If we are unable to hold safe and if we are not able to hold a safe and set of elections, including safe campaigning, to create mistrust in the elections and of course the outcomes, we are operating in a context of imperfect knowledge and science, with multiple variants and outbreak of COVID-19 across the globe. I mean, recently we've got the Delta variant. We have limited vaccine supply, as we have seen, which prevents immediate mass vaccination of the majority of the people living here in South Africa. This means that limited vaccine supply to other constraints mean that some age profession cohorts are not being prioritized. We have seen, so are being prioritized. We've seen the Sisonke take '50s and the over '60s. It may be 10 months before everyone who is eligible to be vaccinated in South Africa and in the region, and with the rate of which it is now.
Allow me to interrupt you and say. Allow me to interrupt you and say.
Yes.
This
means that eligible voter may not fully vaccinated in the time of the elections later this year, and also bearing in mind that there's a 41-day between first dose and second dose. Even with available supply.
Allow me to interrupt you, please.
So I can't hear you.
You make it very valuable. It breaks in between from time to time, and I'm very anxious to hear the joint submission and both ends of it. Technical people, what can we do to make sure that we don't have a breakage of that line, of that connection?
I think it's coming from him. From there.
It's unstable on the other side.
Yeah,
I see. Would you please come back and just try again, because we certainly would like to hear the submission.
Justice Moseneke and the IEC team, it seems that my signal is slightly better. Shall I take over from here while we just try and figure out what is happening with Tinashe's signal? Would that be okay?
Yes, I think you need your colleagues' consent to go ahead, I think, but I'm quite happy to hear you and hear him again later, provided we have another oral presentation by medical scientists. So yes, as long as we keep to the time, please go ahead.
Thank you, Justice Moseneke and your team. So just to reiterate what Tinashe has said is that we believe that as the PHM and HAI, that our submission should not in any way be construed as either supporting for the hosting or non-hosting of the elections this year, because we believe that the issue is so politically contentious and also requires obviously a constitutional amendment and review by our courts. But we would like to set out a few principles. And the first is that if we are unable to hold a safe set of elections, that has an impact on whether the elections are free and fair, both in relation to campaigning and into the actual hosting of the elections. We would also like to say that while we're providing you with some information today, including in our written submission and in this PowerPoint, we are also, as people who are working on these issues, operating in a context of imperfect knowledge, and we certainly don't know all the answers. And unfortunately, we, like many others across the globe, cannot predict the future, but we do warn that the situation is dire. It's dire because we have limited vaccine supplies and limited ability to do proper ramped up testing. And this means that some of the people who are eligible to vote may not even be vaccinated or fully vaccinated by the time of the elections in October. The reason for this is also because we've selected vaccines in the case of one, which requires 2 doses. And so those who are starting in the Pfizer vaccination will still have to wait at least 41 days. In some provinces, it's 21 days for them to receive the second dose. And we'd just like to point out that even in countries where there are sufficient supplies of vaccines, it has taken them several months to get to the point of even close to 50% vaccination coverage. If you look at, for example, the data that's coming from the US and the UK, who started in December 2020 and early January 2021.
Well, whilst you are there, Mr. Stone, as I say, are you going to talk to us at some point about the prospects of us having a certain level of population immunity? And if so, an estimation of its extent? I'm sure you're going to get there at some stage. I'm just asking you on quite early. Thanks.
Yes, we will, Justice Moseneke. We wanted to show you the global context in which we're operating so that when we present the local data to you and some of the early estimates of what is likely to happen in the next few months, it will make sense within the global context. So we just want to go through these few slides quite quickly, just so that you have reference to them and it could benefit some of the work of the Commission or of the inquiry. The one is that this is a situation in relation to Africa and how South Africa fits within the continental context of the rate of positive results. This is self-explanatory, but it does show, particularly in Southern Africa, a key concern around an increase in the number of positive test results that are coming through. The second graph we wanted to show you was just the cumulative number of COVID-19 deaths per million people as at 26 June. And again, it shows a worrying situation towards the tip of Southern Africa, of which South Africa is one part of that. Obviously, there have been a greater number of deaths and a greater impact of COVID in all parts of the world. But recently, the Medical Research Council and UCT has also released a report showing that the number of deaths in South Africa is probably underestimated, and they estimate that at least 170,000 excess deaths have taken place in the period March 2020 to May 2021. This, we believe, is an important slide because it helps, I think, the inquiry to look at the possibility of a greater level of vaccination, not just in South Africa, but in the region and across the continent. What we know so far, Justice Moseneke, is that about 22.6% of the world population has received at least one dose of a COVID-19 vaccine. And as you know, there are multiple vaccines that are considered safe and effective, and each country is using a different vaccines or different combinations of vaccines. About 2.8 million doses have been administered, and now about 41 million is being administered each day. The problem, of course, as you know, in relation to vaccine inequity or the lack of sufficient supplies, is that less than 1% of people in low-income countries have received at least one dose. And we will go into the factors for that, or the reasons for that, or the systemic issues contributing to that. But the reality on the ground is that the vaccination in low-income countries, and particularly on our continent, is very slow and is not likely to result in continental or regional immunity in the next few years. So if you look at this graph, I'm sure you can see the sliver of the orange line relating to Africa, and that shows the number of people who've received vaccine doses. It doesn't mean that everybody is fully vaccinated. It could also just mean that people have received a single dose. And as you know, in South Africa, Pfizer requires 2 doses and Johnson & Johnson's requires 1 dose. But what it shows is that Africa, in relation to the rest of the world, this is what the WHO Director General has been talking about, has received basically less than 3% of the world's global supplies, and our vaccination is proceeding, to put it bluntly, at a snail's pace.
Well, just on that slide, before you move away, the one that holds vaccine doses that have been started by continent. I'm struggling to understand the graphic, just help me through. You've got 100% at the top.
Yeah, so what it means is, of the world's supplies of vaccines that have been administered, if you take that as 100%, most of the vaccines have gone to the green block and to the orange block. So that's North America and Asia, with very little for the yellow block in Africa, and then some in Europe. And we know that in Europe, countries are varying between 30% vaccination coverage to, for example, in the UK, to about 48% coverage. So it shows you where the bulk of vaccines have actually currently being administered around the world.
Well, with Africa, with less than 1%.
Yes. There are supplies now coming in from COVAX and from other bilateral supplies, but even as recently as last week, the chief African Union envoy for the African Union Vaccine Acquisition Task Team has publicly stated that the supplies have basically all been bought up. And so the ability of most African countries, particularly countries in our region, to access accelerated supplies of vaccines in large enough volumes and numbers in a regular, uninterrupted way is obviously at great risk. So, Justice Moseneke, we wanted to...
Ms. Sassan, are you in fact saying that even with our best efforts, we will not have so-called herd immunity in October?
So, Justice Moseneke, I think our scientists and our MEC advisory committee has to advise on that. What we can say is that Africa does not have enough supplies to reach population immunity or continental immunity, not even in the next few years. And this is a position that has also been explained by the Africa CDC as well as the WHO. And the WHO DG has warned that there is now a great risk, particularly for countries that are considered global south or in low-income parts of the world, including Africa, if we're unable to get our hands on sufficient supplies of vaccines. Because if you have, again, to put it bluntly, a drip feed of supplies, it staggers out your vaccination program, even when you are using a vaccine that requires a 2-dose regimen. So it staggers it out even longer.
I hear you, that's helpful, but I'm being quite brutal as well with me. You're really saying to me, there's going to be no population immunity in our particular case, anywhere near the desirable target by October 2021 when we hold elections?
That is what the data is suggesting now, Justice Moseneke, and Peter, when he presents some of the later slides, will explain why we believe that is the case. We don't even think we will reach vaccine, we don't even think we will reach population immunity by the end of this year at the rate at which we are vaccinating and at the rate at which supplies are coming in.
So in fact, again, I know you're anxious to go with the balance of the slides and I'll listen and keep quiet. But in effect, what you are saying is we're going to have to evaluate whether or not the elections are likely to be free and fair, accepting that we will not reach population immunity. Are we likely to reach half of the targets that are set? Or you may not want to express a view, or you may.
Yeah, all we can say, Justice Moseneke, is that it's so difficult to predict, because even when you are guaranteed certain supplies of vaccines, anything may happen. And that's what we said, we're operating in a context of imperfect knowledge. There could be a delay in shipment of supplies, as we've had in South Africa. There could be a contamination at a plant, as we've had in South Africa. There are a number of reasons why the supplies that are promised and that have been signed in terms of deliveries per the contracts that the South African government has entered into may actually not enter the system. There's been some movement in the last few days with some supplies coming in, but even, for example, the facility like COVAX, which had meant to provide the supplies to South Africa months ago, has only in the last few days delivered the first batch of supplies from that particular mechanism. So there is a global supply crisis and there is a global supply chain crisis. And at this stage, I don't think anybody can give a guarantee that what is being promised will actually basically reach our shores. And that's why we wanted to explain to you the global context of what is happening in relation to the pace at which even global north countries are able to vaccinate large percentages of their population, even when they have secure supply chains. If you look at the US, they haven't even reached 50% of coverage, and similarly in the UK, and those are two countries that have sufficient supplies and have actually over-ordered vaccines.
Thank you. You may proceed, thanks.
Thanks, Justice Moseneke. And I think that is a very important point that you raise, and Peter will explain the relationship between what we've been informed about in the last week in relation to the Delta variant and the efficacy of vaccines in relation to the number of variants that are now circulating in South Africa as well. So we will definitely return to that as well. So we're sure that the Commission has already seen this, but we just wanted to basically once again emphasize the situation that we call dire that we're in. And already in the last 24 hours, we weren't able to update this slide, but it obviously shows what everybody knows, which is the upward rise in cases in Gauteng. And then what we're now seeing is potentially a 3 to 4 week lag. And Peter will talk about that in relation to the other provinces as well. And so we're likely to experience the peak of wave 3 quite shortly in the next few weeks. So we were asked to specifically take you through what we know in relation to the number of vaccines. And I think, Justice Moseneke, this links to your question earlier about the supplies in the system and what we've actually been able to achieve. So once again, while we've signed contracts, and we're sure that government must have briefed you on this already, for significant number of supplies, where we're at according to the Department of Health, and there may be some vaccinations that are not captured, so this is sort of the more or less approximate, as at 26 June, is we're under 3 million vaccinations. There are obviously some people who still need to get the second dose of the Pfizer vaccines. So these are just an indication of the number of vaccines administered, which is also indicated through the Sisonke program and the national program. And the Department of Health can provide you with more specific exact data on how many people have received the first dose of the Pfizer vaccine, when they are likely to receive the second dose of the Pfizer vaccine, and then obviously now that the J&J supplies are actually coming into the country, how many people are receiving the J&J vaccine. But if you look at this, and you look at the numbers of people that we have to reach within the next few months to achieve some kind of population immunity, with the disclaimer that we don't know now what the vaccine will mean in relation to the variants, it is obviously a cause for concern.
What is the estimate of 60-year-olds and those with comorbidities? Is that known?
Sorry, Justice Moseneke, I'm struggling to hear you. The estimate of?
I'll try again. What is the estimate of those above 60 and from the National Register? In other words, those who would, if they were to opt for be vaccinated. Well, what would be the straight line number?
So what we've been told by government, and Peter can come in here internationally as well, is that there's a significant number of people who are over 60 that haven't registered on the system. Again, that data is on the National Department of Health website. It shows how many people over 60 who are not healthcare workers or are not school staff that are on the EVDS. And last night in the president's address, he also made a plea that people over 60 need to now walk in to vaccination centers, even without an EVDS registration or SMS, because we are concerned about the uptake for people who are over 60 to receive the vaccines. But having said that, you know, you obviously, if you're going to walk into a center, there needs to be a sustainable supply of vaccines. And so the issue of supplies in the supply chain is also a concern. We can, after this presentation, send you some of the data we have on the over 60 population in South Africa, broken up into over 80 and over 70s as well. And we'll be able to give you that data, both in terms of those who are over 60 that use the public health sector and those that use the private health sector as well.
Thank you. I'll ask Fatima and Catherine to follow up with you, and certainly would appreciate receiving that breakdown.
Sure. And I think that's important because it does speak to the voter eligibility profile as well for South Africa. Justice Moseneke, obviously this number of 2.2 million is, like I said, an imperfect number, because we also believe there are some parallel vaccination programs happening in relation to people who are not South African, who, for example, may be EU nationals, where vaccines are being important for them. So there's a lot of, I think, different vaccinations happening. We now know that obviously teachers have started with their vaccine program, and some vaccines are now being administered to over 60-year-old correctional services staff and some over 60-year-old inmates as well. So this data is changing quite rapidly as supplies come into the country. But we would like to make a few...
I'm sorry, the number 2.6 would be inclusive of the SABC program, right?
The 2.2 would be inclusive of Sisonke, yes.
And what does 2.6 represent?
Yes, sorry, 2.2 and then the 479, yeah.
Sure, thank you. Please proceed.
So just some of the comments we wanted to make about our vaccine program is that we are of the view that it is slow. And obviously we've explained when showing you the global context why we think that is, and that it's affected by global supply chains and global and local regulatory issues too. So irrespective of everybody's good intentions and goodwill, the pace at which we can pick up vaccination in South Africa is totally dependent on global supply chains, which in most cases we have very little control over. And while government anticipates and is doing a lot of, making a lot of effort and doing a lot of hard work to increase the current rate of vaccinations, even if this is achieved, goes to your question earlier, we think it would take well into 2022 for South Africa to achieve population immunity from infection through vaccination. And Peter will talk to what the impact of the variants that are circulating is on that. We've talked about the different vaccines we're using and who that is being prioritized for. And also what's important in respect of the voting age profile or the voter profile in South Africa is that government has also just announced that people over 50 can now start registering, and that if supplies come in or sufficient supplies come in, people who are over 50 would start getting vaccinated from around mid or late July 2021. So Justice Moseneke, I'm now going to hand over to Peter to take...
I'm sorry. You go ahead, please. I'll listen.
Okay, Justice Moseneke, I'm going to hand over to Peter from the People's Health Movement, who will explain more of the scientific, technical details, and then we will definitely take all of your questions towards at the end of it. He's got about 6 slides to go through. Thank you.
Very good, thank you.
Thank you so much. Yeah, this is Peter van Hersden from the People's Health Movement. So I wanted to start with the epidemiological context. So we have entered our 3rd wave of COVID-19 infections, and the peak of the first wave was in mid-July last year, what we call epidemiological week 29 of 2020, and the peak of the second wave was Epi week 2, just at the start in January of this year. Okay, so it looks like as Fatima mentioned, that the 3rd wave will have its peak within the period of the next 3 to 5 weeks. Okay. In other words, what we've seen is kind of fairly consistent 25-week gaps between the first and the second wave, and now we're seeing another 25-week gap between the second and the 3rd wave. Okay, so obviously this is being driven by people's behavior and things like that as well, but it's concerning that we are seeing this regularity. And then on top of that, then we've all heard about the new variants, right? So the first wave was created by ancestral viruses. There was quite some variety of viruses, but these variants of concern that we're hearing about at the moment, Delta and Beta, these are both lineages that derive from the original European outbreaks, the big European outbreaks in North Italy and so on and so forth. And this Delta variant has been judged to be even more transmissible than the Beta variant that caused the second wave, okay? And now the latest data that we have from this weekend is that we think that this is one of the things driving this current wave, okay? You were asking earlier about the seroprevalence, how many people have had COVID-19. So there's actually, we're quite lucky, there's a study out from this National Blood Service and the South African Center for Excellence in Epidemiological Modeling and Analysis at University of Stellenbosch. And Dr. Julian Pulliam from that center estimates that approximately 43% of the country has antibodies, suggesting that they have been infected by the virus before. She goes on to argue that the increased transmissibility, so Delta is estimated to be about twice as transmissible as the original virus and 1.5 times as transmissible as Beta. So then with the current level of immunity, we are not, in fact, in any better position than we were at the start of the pandemic in South Africa. And then, so in other words, the increase in transmissibility is balancing out the population immunity that otherwise would have developed, okay? So the risk...
I interrupted right there, Peter, to ask the question.
Yes.
The 43% of antibodies that the study from Stellenbosch puts out, does that may that be added into our notion of population immunity? Let me put it bluntly and plainly. I want to have a sense of where at will we be in October. In other words, what amount of potential harm to life and limb would occur if we don't have population immunity, or we have population immunity of a certain level in October when we have to go to local government elections?
Yeah.
Get my drift. So I'm trying to get you there to say to me.
Exactly.
This good
Exactly.
news of benefits so that we have 43% of immunity arising from past or historical infections.
So firstly, I'd like to emphasize that when we say 43% show sign of having been infected, that because of the way that the viruses are evolving, that is not translating into 43% immunity, because what we saw with the so-called beta is that it was able to infect people who had been infected with the original viruses. And there is some evidence, but this is lab evidence at this point, that the so-called delta is able to infect people who had been infected with beta. So that means that the evolution of the virus is undermining the naturally acquired immunity that we are seeing in the population. So that's the one concern, okay? The other thing is that if we look at the timing, if this is just, we can expect that by October, we will be past the third wave. However, the question is what factors might contribute towards a fourth wave, which if it carried on, you know, with this progression that we've been seeing up until now, might occur at the end of 2021 approximately. Okay, so we might well not be in a peak of a wave in October, but what does this mean in terms of the risk behaviors and the election? Okay, so I think we can move to the next slide. Fatima?
See,
Sorry, there, thank you. Next slide. Next one. That one, yes. So we don't know enough about the.
we cannot predict this one.
Yeah, it's this one. Okay. So now, so the thing is that we have to recognize that we are working with imperfect science and imperfect knowledge. Okay. So if we look at like the presentation on the weekend about the contribution of Delta to the third wave, then we have to take into account that on average, it's taking us between 30 and 60 days to get the results, that very detailed scientific work of doing the genome sequencing of viruses and then preparing the results is taking about 30 to 60 days to actually give us an answer. And this is what is telling us. So in other words, we are finding out what the mix of variants in the country were like about a month ago, okay? And our testing is, if you look at the figures from the National Institute of Communicable Diseases, you find that most of our testing is so-called passive testing. So effectively, when people show up at a health facility, then they get tested. Since about mid last year, we've done very little so-called active case finding, and we do not have a program of rapidly, being able to see which variants are circulating. It's various technical reasons for that and human reasons for that. Okay.
But just before you walk away, please, two matters that are likely to help you with me.
Sorry, I'm not hearing you quite clearly.
Can you hear me any clearer now?
Yeah, there's just a bit of an echo on your side.
Oh, well, I have three mics that are put in front of me.
Okay, you see. Okay.
I'm going to try. Okay, let me try again. I'm saying there are two matters of some importance for the inquiry. The first is, you say that by October, the third wave could have blown over.
Yes.
Could you say that a little more clearly and more precisely? And the second question is, you said sequencing surveillance takes an average of 30 to 60 days. But the numbers that we see on the screen every morning, are they then delayed by 30 to 60 days? Or it's only the sequencing that's delayed? Thanks. Those are the two questions. Thank you.
Sorry. Yeah, I didn't quite hear the first question, but let me answer the second question, okay? What we saw on the screen, like the graph that Fatima showed, that is from testing. In other words, the PCR, polymerase chain reaction testing, which gives you a result within approximately a day of the test being taken. Of course, depending on backlogs in laboratories and things like that, but it's a pretty quick process. What I'm talking about is when we want to know how many people are infected with beta variant, how many people are infected with delta variant, and whatever the next variant that comes along is going to be called. That is a process of sequencing surveillance. So that's so-called whole genome sequencing, where you take that sample that was now collected from a person, you take it to a specialized laboratory where the whole genome sequencing is undertaken, and that data is analyzed. And that is all relying on a small number of largely academic, but also with the NICD in Johannesburg, not entirely academic laboratories and their workforce. So that is the slow process. So you see that the cases are coming within a couple of days. You know how many cases you've got, at least those that have showed up at the health facility, right? So you're not picking up those cases which are circulating in the community, but people are not going for a test, okay? So you're picking up the numbers quite quickly, but the diversity of what you're dealing with. So in other words, like 6 days ago, Professor De Oliveira, who presented on Saturday, was saying in his Twitter feed that the third wave is being driven by the beta variant of the virus. This is what we as specialists in this field believed. Then the data came in and we realized that actually no, the Delta version of the virus is already here in the community in large numbers. So in other words, even the experts in the field were not up to date within a week or so. Their information was only as good as the processing pipeline, which tells us about the specific diversity of the virus, okay? And the diversity of the virus, as we have now seen, it matters because the different variants of the virus are behaving differently. Is that clear?
Yes, thank you. That is clear. The first question is of some importance also, and it was this. You projected that by October, the third wave, driven by the Delta variant, would have blown over. Would you say that? Would you say that more clearly to me?
So as the South African COVID Modeling Consortium said in the other day, we are having to redo everybody's having to redo their projections, but it is likely, based on our previous experience with waves, it is likely, because October is some months away, that the third wave might well be over by October. We cannot say with certainty, but if they have the similar pattern as the previous waves have.
Thank you. We're going to have to give your colleague who started, I think it's Tanesha, we're going to give him an opportunity to say a few things before we wrap up. We seem to be running out of time. Is he available, and does he still want to make submissions?
No, Chief Justice, I'm covered actually. The two speakers, my colleagues, have actually covered me.
Yes. Excuse me, an overarching and closing question from us would be this. Are you able to give any assessment of the extent and the level of likely harm, frankly, to life and limb, if we were to call out people in October to go and queue up for elections? You may want to venture an opinion, or you may not, but it's obviously central to the inquiry is where will the wave be by way of a projection to what is the likely threat to the right to life and body integrity and the right to access to healthcare. So there's an overarching question and a closing one, which I invite you to express yourself if you are able to make it, to venture an opinion.
Can I just say something quickly and then Fatima can close, okay? So you are asking about the likely harm and the risk to bodily integrity, okay? The point here is it's going to depend on people's ability and willingness to behave in a risk reduction fashion. Okay. Now, there are two worries here. The one is that we have seen poor risk communication. So we know that this is mostly an airborne disease, which is affected by poor ventilation and people sharing air in indoor poorly ventilated spaces. Okay. So now the emphasis that people have on, for instance, hand sanitizer compared to increasing ventilation, this is misplaced. This is the first thing. The second thing is, will people be willing to behave correctly? We have seen unfortunate instances of even political parties spreading misinformation, and we have seen a lack of compliance with the correct risk reduction behavior amongst certain sections of the South African population. Okay, how can we be increasing the proper compliance and thereby decreasing the risk? This is the concern that we have, because if people do decide to embark in high risk behaviors, such as, for instance, gathering in crowds, which is a normal part of a electoral process, then we are concerned about the impact of that. Okay, Fatima, I think you can take it from there.
Thank you.
Thank you, Justice Moseneke. There's just a few concluding remarks we wanted to make, that if the elections were to proceed, and I think it links to your question, I think there's 4 issues to think about. The one is how the messaging will work, because at the moment, the messaging is stay at home and only go out if you need to work or you need basic necessities, even with level 4. So this is an area that is likely to create some kind of confusing messages and contestation in the middle of a pandemic, and it could harm some of the public health measures we're trying to advocate in all of our communities. Because we don't have an electoral system where you can do mail balloting like in other jurisdictions, or where most people can just join a Zoom political rally. We are concerned that political parties want to start campaigning as well, and so how they do that is obviously also a cause for concern. The long queues will obviously require distancing and marshalling, but we'd like to point out that a lot of the work that the COVID-19 People's Coalition has done has been about a fear by communities of the police and army because of the way in which the lockdown has been managed. And so that is another issue that has to be considered: who would do the marshalling for these voting queues? And then, of course, the issue around proper decentralized ventilated site. There's a number of aspects about how you would actually have control measures within the voting stations and outside of the voting stations, and how you would actually make it safe enough for people to want to actually venture out, to leave their homes, to leave their communities, to go and do the voting. And so we believe that those are some of the issues that have to be considered. But again, we are saying that we do believe it's risky. In whatever way in which you try and do this and manage it. There's multiple risks, both from a public health point of view, but also other risks as well, which are mainly political. And that's why we wanted to end with some recommendations around ensuring that the inquiry actually consults as a matter of urgency with the Africa CDC and the WHO, because we have had experiences in 2 other jurisdictions, the DRC in relation to the Ebola outbreak and what happened in relation to community trust and trust building and political violence around a set of elections that proceeded there in the middle of trying to manage the Ebola epidemic. And there's a lot of best practice lessons to learn from that. That deals with the political risk. And then the situation that happened in India a few months ago, where the Indian government decided to proceed also with a set of local elections, which many believe, and there's some articles that have been written about, academic articles and medical journal articles about what that means for how variants circulated and how they had to deal with more cases, which has actually resulted in a ban on exporting vaccines to other countries. So we won't go through all of the different recommendations because this is included in our PowerPoint presentation, but we did want to flag the case study of India and the case study of the DRC, which we believe the Africa CDC and the WHO would be best placed to explain. That what is very concerning and worrying for us is that when there was community mistrust about why the elections were proceeding or not proceeding in the DRC in managing the Ebola outbreak, Ebola clinics were actually attacked, and public health people and healthcare workers were attacked because it was seen as a political ploy to try and remove certain political parties from power. And then obviously we've shared these many links with your team, and we will obviously share the information about the demographic disaggregation about people over 60 with you shortly. Thank you.
Thank you. Once again, thank you for the submissions, both written and oral. Yes, we will look at the WHO experiences in India and DRC. We will certainly, we have seen your suggestions on what steps to take to make possible elections safe. We'll explore that. But yes, it is so that this is a highly contested terrain. You need only to go to our website to see just how much the views are varied and how people think that. So it's a very contested space. What remains though from what Phil has said is congregating is a no-no if it is in spaces which are not decentralized and are not properly ventilated. We are most grateful, and we will going to get to our next presentation very shortly. And please do send us whatever might be available. It was going to turn all on civil societies like yourselves and knowledgeable professionals. And of course, the contestation in the political terrain will remain quite varied, I think. But this is helpful. Thank you.
Thank you so much.
Sure, thanks so much, Ms. Housen. Thank you, Peter and Tinoshi. I hope I will pronounce the name correctly.
Thank you so much. Thank you.
Keep up the good work. Thanks so much.
Cheers.
Guys, we're going to turn to our next presentation, and that is coming a little later. We're running how much late? We should have started at 1:45, so we're 10 minutes late. Is that what you're saying?
The next presentation.
Oh, we have a bit of time. It's only coming at 1:45. That's what you're saying. Okay. Sure, thanks. Well, we're going to break now anyway, get some sustenance, and we'll be back then at 1:45. Is that okay? Okay. Thank you guys, well done. The tech team. Tell me, how are you linked up with the television crew?
We gave them the Zoom link.
Oh, you gave them the link. I see. So they could put it up when they want to or not, and they'll use the pass they want to use. I see. Oh, great. Thank you. Carefully, you're sending me the agent Zoom link to what end? For the present one. Did I need it? I mean, or is everything in front of me?
Yeah.
Pues son niñas, ¿verdad? Niña.
We just changed the battery.
Yeah. Well, let's go get the fire. 5 weeks, etc. So we can go back to the article, please. Saturday. Yeah, about 2 weeks. So, just shutting down. Yeah. No, it wasn't. Second. Yes. Yes. That's one.